Hello, everybody. Welcome to tonight's HFSA Heart Failure Patient and Caregiver Webinar, Heart Failure Basics. My name is Sean Riley. I'm a member of the HFSA Patient Committee. I'm also a heart failure patient myself. Before we get started, I'd like to thank and recognize our sponsors, Merck and Novartis. Today, you'll be treated to presentations by heart failure providers Arianne, Agdamag, and Nunzio Gaglianello. They'll provide a foundational overview of heart failure, including its primary causes, symptoms, and how it's diagnosed. It also covers initial treatment options and highlights key lifestyle changes that can support heart health. It's intended to give attendees a better understanding of the condition and learn practical strategies for managing effectively. We'll take questions and answers from the question section to present to the speakers at the end of both segments. Also, at the conclusion of the webinar, you'll receive an evaluation for this event, and we would appreciate if you'd complete the survey. Okay, our first speaker is Arianne Agdamag. Dr. Agdamag is a staff physician in the Heart Failure and Transplantation Medicine section at the Cleveland Clinic's main campus. She is board certified in multiple specialties, including internal medicine, echocardiography, nuclear medicine, cardiovascular disease, and advanced heart failure and transplant cardiology. Welcome, Arianne.
Thank you, Sean, for your kind introduction. And I would like to extend my welcome to everybody who has joined us for this webinar. As Sean mentioned, I am here to discuss an overview of heart failure. So heart failure, as we know, is a complex clinical syndrome, and it can be from structural or functional heart issues that can affect the ability of the heart to fill or eject blood. It often results into a difficulty of the heart to meet the demands of our body in terms of perfusing our body from that standpoint. There are multiple symptoms and signs that manifest as heart failure. Those that we are most familiar with will probably include fatigue and dyspnea, which stands for shortness of breath. And for signs, it can manifest as fluid retention, which we can see as leg swelling, weight gain, and then it can also manifest as exercise intolerance. It is a progressive clinical syndrome, meaning that through the years, as people have heart failure, they will fluctuate in terms of the severity of their illness. And it often involves the interaction of multiple systems in the body. Although we primarily talk about heart failure, it is often affected by other organs as well. Now we will proceed to talk about the causes and risk factors of heart failure. You may ask yourself, what predisposes me to develop heart failure in the future? So here is a schematic diagram of other things that may cause heart failure: arrhythmia or bad heart rhythms. This can be in the form of what we're more familiar with, such as atrial fibrillation, supraventricular tachycardia, and the like. Damaged heart valves. They can either be too tight, which is manifested as stenosis, or regurgitation, which is manifested as leaky valves. High blood pressure, excess alcohol, atherosclerosis, which signifies blockages within the coronary arteries, heart attack, inflammation of the heart muscle. We may often hear that as a term called myocarditis, and weak heart muscle as another possible cause. To further reiterate this, some of these have already been discussed previously. However, there are other things that I would like to delve more deeply into on. One of which is called the congenital abnormalities. These are people who are born with already inherent heart condition. They may have either holes in their heart, leaky valves, or incomplete heart vasculature from that standpoint. Genetic cardiomyopathy signifies something that is hereditary, something that we may have inherited from other family members, or we may be the first person in our family who carries the gene that leads to heart failure. Infiltrative cardiomyopathy is when there's abnormal protein or iron deposition that can lead into the heart muscle being thicker. Inflammatory cardiomyopathy, just like what we discussed earlier, is when there is inflammation of the heart muscle, either from prior illnesses. We may be more familiar with this in the setting of COVID. Chagas disease from other infectious sources, sarcoidosis, which we're more familiar with as lung issues, and ICI, which stands for immune checkpoint inhibitors. These are medications that are often used to treat cancer patients. Other disorders, such as thyroid issues and diabetes, also predispose patients to develop heart failure. Chemotherapy, radiation therapy, and other illicit drugs are other causes and risk factors. So, what are the types of heart failure? You probably often hear the term ejection fraction or the squeeze function of the heart. That is often what is used to quantify the degree of heart failure that patients have. The way that heart failure has been classified has been modified throughout the years, but as of most recent, this is how heart failure is classified according to ejection fraction. When the ejection fraction is less than 40%, it is classified as reduced ejection fraction. Between 41 to 49%, it's classified as mildly reduced. Anything above 50% is preserved ejection fraction. As you can see, patients will fluctuate between one level and another. And at one point, there may even have improvement of ejection fraction, and that is when the ejection fraction increases by more than 40% and 10 points higher than their baseline. What are the symptoms of heart failure? It can manifest through multiple means and multiple symptoms. As shown here in the diagram, some patients may have chest pain or chest discomfort when they're walking around, shortness of breath, dizziness or lightheadedness, any swelling of the legs, hands, or feet, sudden weight gain, and sudden fatigue or weakness. On the left side, you will be able to see some terms, a little bit more medical, but I will go into them more deeply so that we will all be able to understand these symptoms. Paroxysmal nocturnal dyspnea is when patients often wake up feeling short of breath. Orthopnea is when patients have shortness of breath that causes them to require multiple pillows because they are unable to lay flat. Bendopnea is when patients have shortness of breath when reaching over or bending forward. Apart from this, some patients also manifest heart failure with a lack of appetite or a sense of abdominal bloating or fullness. There are different ways by which we also categorize heart failure in terms of their functional capacity, which is why your providers or other physicians may always ask you, how much can you do in a given day? This is classified according to the New York Heart Association class. It goes into 4 different levels. 1 is when you have no limitation with any type of physical activity. 2 is when you have some slight limitation. 3 is when you have marked limitation, and 4 is when you have symptoms at rest. Depending on any given day or any given time that you follow up with your provider, you may fluctuate between any of these classes. Another term that you will also hear in heart failure is the stage of heart failure. It also comes in 4 stages, A, B, C, and D. A is when you have high risk, meaning you have risk factors for it, but you don't have any evidence of damage in your echocardiogram or ultrasound of your heart, and you also don't have any symptoms. Stage B is when you have an ultrasound of your heart that shows you have some damage in your heart, however, you are not having any symptoms. Stage C is when you have evidence of both damage in your heart as well as having symptoms such as the shortness of breath or weight gain and swelling of your legs that we explained earlier. And stage D is when patients have symptoms that are not quickly addressed with medications alone. These patients are frequently readmitted to the hospital because it's been difficult to manage them with just oral medications. Now you may ask, how do we diagnose heart failure? It's actually based not just on your ejection fraction, but also on your history and your physical exam. There are multiple things that your providers look for when they examine you. They look at your exam, whether or not you have any evidence of fluid buildup, either through your neck vein, evidence of fluid buildup in your belly, or any swelling in your legs. They examine your pulse. They look at when they listen to your heart, they assess if you have any abnormal murmurs or any evidence of abnormal heart sounds that can be a sign of heart failure. And then they also ask you about not just about heart symptoms, but they ask you about other symptoms as well, such as your urine output, your appetite, nausea, vomiting, and whether or not you've been having any cough. Out of all of these, it's orthopnea, or inability to lay flat, and also requiring multiple pillows to be able to sleep well at night, as well as edema or swelling in your legs. These are the ones that are actually very predictive of heart failure from that standpoint. Jugular venous pressure, that is when the providers examine your neck vein, because that neck vein is a surrogate marker in terms of the fluid level in your heart. The way I describe it to my patient is it's like a dipstick. When you measure the oil in your car, it serves as a gauge in terms of the fluid level in your heart. And then we listen to your heart with our stethoscope to see if you have any third heart sound, which is also a manifestation of heart failure. What are the tests and imaging that your provider may request? So in terms of blood work, you probably often hear the term BNP or NT-proBNP. BNP stands for brain natriuretic peptide. This is a protein or peptide released by your heart muscle in response to stretch or in response to fluid buildup. We often use that to trend and help us prognosticate how you are doing in the heart failure spectrum. Basic metabolic panel is when we check for your kidney function level and your electrolyte levels. Complete blood count, we try to determine your hemoglobin level, red blood cell count, and then we also check for iron studies because iron has been repleting patients' iron levels, most especially among heart failure, has been shown to help improve their functional capacity. We also check for your thyroid levels as well as your hepatic function panel, which stands for checking your liver function test. Apart from blood work, there are other tests that your provider may request from you, and some of these may be familiar to you. One of which that helps us assess the ejection fraction or the squeeze function of your heart is a transthoracic echocardiogram, as you see on the left side of the screen. That's basically an ultrasound of your heart. There are multiple ways to get an ultrasound of your heart, either through a probe into your mouth and food pipe, which is more specialized, or the more common one that we have is through your chest wall. And then in terms of more advanced testing, your provider may also ask you to do what we call a cardiac MRI. That's when you go into this hollow tube. It gives us a better characteristic and better idea of your heart muscle function and to see if there's any evidence of protein buildup, inflammation, or scarring in your heart. Right heart catheterization, as you can see in the picture on the bottom right of your screen, is when a catheter is put either in a vein in your arm or in your neck, and that helps us gauge the pressure within your heart, which is a surrogate marker for your fluid buildup. It also helps us assess whether or not your heart is pumping effectively or efficiently and providing enough blood flow to the rest of your body. We also do a special type of stress testing. Unlike the prior stress testing that we use to determine if you have any significant blockages, we do a cardiopulmonary exercise stress test where we put a mask over your face and ask you to exercise. And we use this to help gauge which patients are on the spectrum that will be requiring advanced therapies, such as heart transplants or heart pumps down the road. Other testing that your provider may request include a cardiac CT or a CAT scan. This helps us get a better understanding of your heart structure, including your coronary arteries and other relevant structures that we're trying to assess. Stress tests to assess if you have any significant blockages, and a left heart catheterization, which looks into the arteries of your heart to see if you have any significant blockages that may require stents or may require open heart bypass surgery. I will pass on back to Sean for this time.
Well, thank you, Dr. Agdamag. A lot of great information. I certainly remember when I was first diagnosed with heart failure, a lot of these tests that you described, they did on me, and I had a million questions to ask the doctor. So this is great that people are able to get this information from you tonight. Our next speaker I'd like to introduce, or before we do that, I'd like to remind participants, if you want to post questions, you can post them in the questions section, and again, we'll we will field questions. We'll do question and answer at the end of the session. So our next speaker is Dr. Nunzio Gaglianello. Dr. Gaglianello is an associate professor of medicine in the Advanced Heart Failure and Transplant Cardiology section at the Medical College of Wisconsin. He also serves as the program director for the Cardiovascular Medicine Fellowship. A graduate and advanced heart failure trainee of the same institution, his interests include advanced exercise hemodynamics and participation in a range of clinical trials related to heart failure cardiology. Welcome, Dr. Gaglianello.
Thank you, Sean, and thank you, Dr. Agdamag, for that fantastic introduction as well, and thank you to the HFSA for inviting me. The next part of this talk will be heart failure prognosis, and then we will discuss treatment options as well. The tricky part about heart failure, if you don't see it across the continuum, is that we can make people better, particularly when they have those episodes of decompensation or shortness of breath. Like most patients, we have multiple treatments, which we'll discuss in future slides, but we also can give people diuretics and people can feel better. And so it is a variable course, and over time, people become weaker. As Dr. Agdamag had mentioned, this is a progressive disease process. And so people will find a new baseline, continue to live their life, have another decompensated episode. And in that time, our brains, and when you're seeing us in clinic, are always trying to sort of risk stratify patients that we're seeing and kind of defining how sick is ultimately sick. And that's kind of the gist of what we're trying to do at a basic clinical visit when you're seeing somebody with the tests that were previously discussed. So one option is if people are getting admitted for heart failure, we in our minds are trying to risk stratify you and looking to see an index hospitalization is a opportunity for us to make sure that we have everything appropriate, make sure you're on the right medications, and really make sure that we have you in the right pathway so that we can treat you and give you the best quality of life and survival that we can possibly do. What are concerning signs for heart failure? These are things that we get concerned about as physicians. So there's standard medications that people should be on, and there's 4 of them, and we'll discuss those in the slides in the future. But if you can't tolerate the medications that are supposed to make you feel better and make you live longer, those are concerning signs. Also, we look at lab values. That's why we order basic lab tests. We look at proBNPs. We also look to see if your serum sodium level is abnormal, usually on the lower side, if that means hyponatremia. That usually means that you might have too much excess fluid, or your nervous system might be too activated that you're retaining all this extra fluid so that your body is getting enough blood flow to your kidneys. Another sign is if you have ongoing renal dysfunction, or meaning that your kidneys look worse on lab markers and lab values. That could be a sign that you're not getting enough blood flow to the rest of your body. So there's no golden magical bullet here. This is the art of sort of what we do and have a discussion with our patients in clinic. Other things that providers and people who are known about this is a mnemonic, a fancy mnemonic that is co-sponsored by the HFSA as well as the ACC. And it's a pretty easy mnemonic to follow, and it's I need help. So if you've ever been in the hospital and you required any of these medicines to make your heart squeeze stronger so that you're giving more blood flow to your kidneys so that you can get fluid off, that's a concerning sign, and that's a high risk feature of what we would prognosticate somebody from heart failure. As we had discussed previously, the New York Heart Association classification, if somebody is symptomatic or has minimal exertion and have symptoms, that's a concerning feature as well. And those markers of those circulating levels of heart failure, if they're elevated and they're consistently elevated, or if they're relatively normal and they start going in the wrong direction, that increases our clinical acumen that something else might be going on. We discussed renal or kidney and liver dysfunction. Those are concerning signs that the heart is sort of connected to both the kidney and the liver. And so if you have too much extra fluid or not getting enough blood flow, those enzymes or levels that we look for are poor. Obviously, squeezing function and having a low squeezing function in particular, less than 25% on an echocardiogram, is concerning. Most patients will have a defibrillator, particularly if their squeezing function is low, less than 35%. And if that is giving you shocks, or if you're having therapies from your defibrillator, that's also a concerning sign. Hospitalizations, as we discussed previously, and if we have to keep going up and up on the water pills to make you diurese or get fluid off of you, it's always concerning if we can't keep the fluid off of you and your body is kind of overcompensating and is kind of beating our medications that we're trying to do. Low blood pressure also is concerning, as well as what we had discussed earlier. If we can't go up on these medications, our goals in clinic always are to get you on the highest doses of these medications to improve your functional capacity to the blood pressure that you can tolerate these medications at. And you might be like, this is crazy, and why is my doctor pushing this and asking me to do this? But we have pretty great data to suggest that the higher the doses of these medications that we can get you on early up front can delay your disease process. And most heart failure cardiologists like to keep your blood pressure in that 90-ish range as long as you can symptomatically tolerate it. And so it's kind of as high as we can go from the medication standpoint. So let's talk about the management. This is kind of an overlap from these aspects. I think with all cardiovascular disease processes, obviously having a balanced diet, I believe exercise is very helpful in regards to heart failure patients. It's kind of a double-edged sword. You're symptomatic. It's hard for you to exercise, and then people become more sedentary. And so we try to instill at least having a routine. Obviously, maintaining a healthy weight, smoking and alcohol, we all know is bad for us. And managing appropriate stress. So what does everybody and every heart failure doctor talk about when you see somebody with a new diagnosis? These are the four medicines, or how we call them, the four pillars of heart failure medications. These are the four medicines that we're going to try to get you on if you can afford them, if your insurance company covers them, to give you the best chance at survival and potentially to improve your heart function, as well as to, even if your heart function remains low, to continue to give you the best quality of life for the longest time period that we can. And we know being on these four medications improves your survival to a relative risk reduction of 73%. And essentially, every 1 in 4 patients will have an improved survival significantly. So what other things are there? So this is what I like to call is the building blocks of heart failure therapy. And we talked about the beta blockers. We talked about the ARNIs or Entresto medications that you may have heard. The beta blockers are the carvedalols, the bisoprolols, the metoprolols. The mineralocorticoid receptor antagonists are the spironolactones or the eplerinones. And then there's the new kids on the block, finerenone. And then your doctors have probably also talked about the SGLT2 inhibitors, or dapagliflozin and empagliflozin. Those are the four main pillars of medications that we try to get you on. Then it's kind of depending on your pathway. So most patients, if your ejection fraction over 3 months remains less than 35%, we recommend that people get a defibrillator, because we know that people who have weak heart muscles are at risk for something called sudden cardiac death, meaning you have a bad heart rhythm and you could pass away suddenly. What we don't know is we are not good at picking out individuals on a one-on-one basis and saying that is the person that is going to have that bad heart rhythm. And as a societal value, we've decided that it's a cost-effective to essentially implant everybody with low ejection fractions, because we are not at that granular level yet to essentially say that person is at higher risk compared to the other person. Then there's cardiac resynchronization therapy, which I believe is the next slide. And we'll talk about that briefly. Then there's left ventricular assist device, and kind of the creme de la creme of the pyramid is transplantation. These other options are a mitral clip, which can ultimately help if you have a leaky valve, and some of these other medications may help as well. So what are defibrillators and cardiac resynchronization therapies? Defibrillators are essentially a device which has a battery packed and sometimes goes into your heart and essentially monitors your heart and is programmed for bad heart rhythms. And what it will do is, if you have one of those bad heart rhythms, it'll either try to pace you out of that bad heart rhythm, or it will give you a shock to get you back into a normal heart rhythm. There's something called a QRS complex, which is something that we look at on EKGs, and cardiac resynchronization therapy tries to essentially make both the right and the left side of the heart squeeze more synchronously. When you have a wide QRS, it means the right side of your heart and your left side of your heart are not squeezing at the same time and using energy inefficiently. And so we put an extra lead if you qualify based on how big your EKG is wide, to try to make the right and the left side squeeze more synchronously. And we know that that has a survival benefit. That also has a functional benefit for patients to feel better, walk more, and just ultimately do better. That's not for everybody. You have to have a QRS usually greater than 150 milliseconds. And some patients will qualify based on a QRS of between 124 to 150 milliseconds. So other things that we look at, most patients will get a cardiac catheterization. So what we do is we look at your arteries of your heart. There are two pathways of a cardiomyopathy or a weak heart muscle. Some are, we don't understand the complete reasoning. We call those non-ischemic cardiomyopathies. That means people don't have blockages in the arteries of your heart. Other people may have significant coronary disease, meaning you have blockages in the arteries of your heart, or you had a heart attack, or you've had stents placed into the arteries of your heart. If you've had stents placed in the arteries of your heart, it opens up that blood vessel, and sometimes can make your heart muscle improve. That being said, sometimes we present late, or sometimes you still have high cholesterol, ongoing high blood pressure, diabetes, which can continue to create that process. And as we had discussed, this is a progressive disease process. So sometimes we put stents to make people do better as well, particularly if you're having a heart attack. Sometimes people get bypass surgery if you have more than one blood vessel that's blocked, or the main artery of your heart that's blocked as well. And those can have survival benefits associated with that. Some patients will present with leaky valves. And if you have leaky valves after we've gotten you on all of these medications, your physician might refer you to a mitral clip, which is essentially a transcatheter through the vein across the upper part of your heart, and a little clip that essentially cinches that valve so that blood is not going in the wrong direction, with the goal to improve your quality of life, to make you feel better. Other types of valves are surgical valves. And if people have stenotic valves, meaning tight in this area that separates the main pumping chamber to the rest of your body, is one valve. And then there's the mitral valve here that we discussed here. There's a surgical concept for that. So those are sort of the treatments of how we think of things. Patients can also be monitored, because it's obviously not easy to follow this and live with this disease process on a day-to-day basis, right? It requires a lot of medication changes, requires titration of your water pills. It can be frustrating to follow a fluid restriction or a diet restriction. And so sometimes your doctor will say, well, you're a little difficult to manage. And so we're recommending that we implant a device that can ultimately go into one of these distal blood vessels in your lungs, and it can actually measure what the pressures are continuously to your heart with an electronic pillow. And what we know is that by having this, we can predict people's having heart failure hospitalizations, and we can prevent you from having these symptoms. And so by having this change early, we can essentially adjust things and stay on top of this before you have symptoms. So the $1 million question is, what happens if I advance to heart failure, or more to an advanced heart failure state, right? If you come to the Cleveland Clinic, or if you come to the Medical College of Wisconsin, what we're going to ultimately do is try to optimize your medications. That's the first thing that every heart failure physician is going to ultimately attempt to do. Then we're going to see if you have options for surgery, valves, bypass surgery, need stenting, those types of things. Those have usually been done at other places. And then obviously we look for heart transplantation, mechanical circulatory support, doing all those other tests, the cardiopulmonary exercise test, the right heart catheterization. And we determine if you're a candidate, or if you would want that in a collegial discussion for heart transplantation, mechanical circulatory support. And sometimes, unfortunately, people present too late, where we don't have any good options, and we actually think these life-saving procedures may be more dangerous to move forward with. And we recommend patients potentially go home with either an IV medicine to make their heart squeeze stronger, and we take a palliative approach to heart failure therapy. So how do we make a rusty old car look like a fancy Lamborghini, and why sometimes are patients not candidates for these things? So back to our discussions, poorly controlled diabetes. If you have essentially scarring of your liver to a degree that your liver is not able to essentially filter the poisons of your body. If you have bad kidney dysfunction, obesity is usually a contraindication to cardiac transplantation. Age as well. And then sometimes tobacco and substance use disorders are also are contraindications in moving forward with transplantation. I'm going to go really fast here because I'm out of time. This is an LVAD. This is a therapy that has a great survival. These are for patients that are either older 70 or aren't transplant candidates, as we discussed previously. It's an implantable open heart surgery. And this is what it looks like. It's a pump that goes into the main pumping chamber of your heart and bypasses your heart to your aorta. And the final thing is heart transplantation still remains the gold standard for patients that have end-stage heart failure. I went over 1 minute, I believe, but thank you, everybody, for your time.
Well, thank you, Dr. Gaglianello. A lot of great information there. Yeah, we'll move right into the question and answer segment. First question, Marilyn asks, her ejection fraction is 78, and she forgot to ask her doctor if high ejection fraction can be bad.
Arianne, you want to go? You want me to go?
Sure, I can go first. So when I see somebody with a high ejection fraction, I want to make sure that the patient's not dehydrated. That's one thing that I try to look for as well. And then the other thing too is there's other signs, there's other disease processes that can manifest as high ejection fraction, like hypertrophic cardiomyopathy. So that's when the heart wall muscle is on the thicker side. So those are the things that I try to look for whenever I see an ejection fraction that's high. Granted, if those are not present, I usually say it's fine. We just continue to monitor, make sure that patients are well hydrated, and monitor to see if there's any signs of obstruction based on the other ultrasound of their heart findings. And Nunzio, feel free to add on from that standpoint.
Yeah, I think at that point, having an ejection fraction above 70% is sometimes concerning for some other process. Sometimes hypertension can lead to that, where you develop a thick heart muscle. There's another disease process that we would probably look at and called amyloidosis. And sometimes ladies in particular can have higher ejection fractions, particularly as they age. And you can end up having diastolic heart failure or heart failure with preserved ejection fraction from that aspect. But that's, yeah, absolutely things that we would be looking for from that standpoint.
Yeah, if I can comment on that too. So I myself, I have amyloidosis. So I've got cardiomyopathy, but my ejection fraction is preserved. So there's a case there where the ejection fraction remains fairly high, but there's obviously something going on. Okay, our next question, Richard asks, which test is most important for deciding if you qualify for an ICD? And what are the differences between transvenous and subcutaneous ICD?
So in terms of qualifying for ICD, there's multiple criteria that our electrophysiologists use, one of which primarily is the ejection fraction, but one we weight that patients have to be on guideline or good guideline-directed medical therapy, meaning good heart failure medications. And despite being on good medications, if your ejection fraction remains 35%, then you qualify for an ICD. Now, just like what Dr. Nunzio mentioned earlier, there are different types of ICD. There are those that have 3 leads versus 2 leads. When do you qualify for both? That is dependent on your EKG findings. And in that EKG or tracing of your heart, we look at certain measurements to see whether you will require the 3 leads versus just the 2 leads. And then in terms of the transvenous versus subcutaneous, the way that they are implanted or put in is very different. Transvenous, there's usually a can that's on the left side of your chest, and then the wires go through a vein in the vein. And from the vein, they are implanted directly or screwed into your heart muscle. For subcutaneous, the can is usually on the bottom part of your chest and over actually to your abdomen, and then it's implanted underneath the breastbone. So it's not directly inside your heart, but it's right outside your heart. And in terms of whether you will be a candidate for one or the other, the electrophysiologists or electrical doctors make that determination at the time when you see them for these devices.
Okay, our next question, Jim asks, how frequently should one bother with a CPT? And also maybe a 6, pardon my I don't understand or recognize this term, a 6 MWT is sufficient for monitoring changes?
So that's a It's a great question. I think that the answer is ultimately going to be it depends. Um, I think if you're, so we have cutoffs on the cardiopulmonary exercise test. So I think we should start there. So what we're looking for is usually a VO2 max of less than 14 or less than 12 if you're on the beta blocker type medications. And then there's other parameters that can qualify or that we look at, but that's kind of getting into the details and the nitty gritty of a cardiopulmonary exercise test. But I think that would depend so let's take, for example, your VO2 max is 23, 24, and you're doing great on medications and you have minimal functions. That's somebody that I would probably see 6 months to every year and just kind of discuss and get a sense of if they're even having changes and maybe do a CPET every 2 to 3 years just to kind of check in. If somebody's starting to slide or they're coming down on their medications or they're just telling me, hey, or they're with their wife and the wife never lies, particularly when there's a male there, and they're telling me that they're sliding a little bit and their VO2 max is 15, that might change my risk stratification component of it and say you're close. And should we repeat that maybe in 3 months, maybe in 6 months, and just keep a much closer eye on you based on your functional capacity? Because that slide that I had shown, right, it's really tricky to tease out the change in functional capacity over a long time period. And there's a lot of this notion of, well, I'm just getting old and I can't do the things that I used to be able to do. I hear that frequently in my clinic. And so I think the closer you are to that 14, 12 or other high risk features, probably more frequently. I think a 6-minute walk test is a pretty easy test to do. We don't do those frequently in our clinics, but I know there's data to suggest that if you can't walk 300 meters, particularly if you can't or don't have the orthopedic issues to walk on a treadmill, that's always a concerning sign from that standpoint too. So that one's even easier than a cardiopulmonary exercise test. I think to segue to a next question, then I think if you're kind of right on that cusp, the conversation is, how poorly do you feel? Should we do a right heart catheterization? See, are there other things to ultimately optimize you? But that CPET is sort of the holy grail of the data that we have right now to say this is really time where we think your survival from a heart failure perspective is worse than kind of doing some of these more aggressive therapies from that standpoint. I hope that answered your question.
All right, great. Next question, Claire asks, she says her mom is 81 years old, has COPD, and has all the markers for heart failure. She's getting an ultrasound tomorrow and blood work was done today. Claire says she's here to learn. She says her mother's been miserable and she wants to know, is there anything that she can do for her mother right now?
Claire, I hope your mother feels better, but I think you already have a plan in place, starting with the blood work and getting the ultrasound of her heart tomorrow. One thing that I usually ask patients and family members is that having a regular blood pressure, heart rate, and weight check will really help your physician who you're going to see after they evaluate and review all your testing. That will help give them a sense in terms of how they can adjust medications for you. So in terms of what you can do while you're awaiting your next clinic visit, I will say taking regularly the blood pressure, heart rate, and weight, same time each day, keeping a trend and bringing that log during your next visit. When you bring your mom to the next appointment, I think those will be very helpful as we're still waiting and getting more information at this time.
Excellent. Okay, our next question is from Lorraine, and it's for Dr. Gaglianello. During your discussion, she's asking, what did you specifically mean by wanting the blood pressure to be in the 90-ish range?
So if you think of the heart as kind of a pump muscle, and the analogy I use sometimes is if you have a hose and you have a hose that's kind of tight and you have to squeeze against that hose, it's going to make it harder for the heart to pump blood forward. And so we know the lower that we can get your blood pressure, as long as you're not having symptoms, meaning you're not dizzy all the time, or you're not fatigued, or you're worried that you're going to pass out. We try to essentially optimize or maximize the amount of blood flow that we can give you that's going to the rest of your body to try to make you feel as good as we can and trying to optimize that. So that's usually one way as a surrogate versus doing invasive tests is As long as you're not symptomatic and you can tolerate those medications, usually like a blood pressure of 90s is where I will try to push my patients. And that's not for everybody. And that's that's a generalization that if you're not having symptoms in the 90s, some doctors may go, oh boy, your blood pressure's too low. In our world, we kind of like you lower because in our minds, that means we're trying to maximize the amount of blood flow that your heart is giving you. And that's kind of is sort of that sweet spot in our minds of we think we've got you as optimized as we can potentially optimize you without doing other things.
Excellent. Our next question, Lauren asks, is it better to start an ACE or a BB first in therapy?
So if you have heart failure with reduced ejection fraction, that's when your ejection fraction is less than 40%. We usually want patients to be on as many guideline-directed medical therapy as possible, even if you start at low doses, so ideally both for those, and then go up as tolerated. So as to preferring one or the other, ideally, we want them on both. Granted, there's a lot of caveats to this, meaning if they had prior cardiogenic shock and all those, but that's for the more severe patients. But ideally, if you have a newly diagnosed low ejection fraction, then we want you to be on both as much as possible. It's different if you have heart failure with preserved ejection fraction, because at that point, it's really all about controlling your risk factors. If it's hypertension that you have, then that's when the ACE inhibitor or ARB may be better in terms of controlling that, if that's what's driving your symptoms. If it's atrial fibrillation that's driving that, then preference will be for metoprolol at that point. So for the preserved ejection fraction, there's a little bit more nuance depending on what the underlying reason is. But if you have reduced ejection fraction, both at the same time start with low doses and then titrate up as tolerated.
Excellent. Okay, I think we have time for one more question. Jim asks, it seems to me that stroke volume is more important than ejection fraction. Should we be paying more attention to stroke volume?
Jim is an intelligent man. I think ejection fraction can be messy. Yes, I think stroke volume, I think cardiac output is a surrogate of stroke volume. I think you need to really get into that nitty gritty, you need to get invasive testing to really get the true data from that standpoint. I use ejection fraction as a risk stratifier of patients, but if somebody's ejection fraction is still normal and they're telling me they have heart failure symptoms, particularly in that HFpEF population, then we might do right heart catheterizations if I can't manage them with medications. I'm not aware of specifically looking at stroke volume. I know there's data to suggest if you have a long-term low cardiac output, there's a trend towards that's not a good long-term sign, just like if you can't functionally walk. But I think in our world, ejection fraction is a way to just get you into the right treatment pathways. And ultimately, I think you're right. Yes, stroke volume is the essence of everything your heart is trying to do. Ejection fraction is just the best way of essentially risk stratifying you in regards to a pathway. But at its essence, stroke volume is the true point. I'm not sure I answered your question, Jim. We don't look at it specifically. We look at cardiac output, I think is really, and your cardiac index. And then we look at pressures and volume and really try to see if we can optimize you from that standpoint. But at the end point, it is the heart's inability to pump enough blood to the rest of your body, which is ultimately stroke volume. And when your heart has to compensate by going up on the heart rate, and that's how you're living, I always say that to my fellows, right? If you're living on a heart rate to maintain that forward flow, that's always a concerning sign.
Okay, unfortunately, that's all the time that we have. So thank you, a lot of great questions. I'd like to thank our speakers, Dr. Agdamag and Dr. Gaglianello. Awesome information that you put out today. Thank you very much. We'd like to thank our sponsors, again, Merck and Novartis. And most of all, we'd like to thank all of our patients and caregivers for joining the webinar. I'd like to remind all participants that the webinar will be available on demand. And I'd also like to remind attendees to complete their evaluation. It'll be sent in an email following the webinar, and we really appreciate the feedback.